So as you're all very familiar, autosomal dominant PKD is the fourth leading cause of end-stage renal disease. The growth of cysts, back one please. The growth of cysts results in kidney growth and increased kidney volume. And what we're going to focus on tonight is that this cyst growth activates a number of kidney hormones, and these are based on the system called the renin-angiotensin-aldosterone system. Okay, I think I have control now. Okay, and this renin-angiotensin-aldosterone system is a hormone that's very much involved with blood pressure regulation. Can we go back one, please? Thank you. Although there's been a lot of small studies of blood pressure regulation in polycystic kidney disease, there really isn't a definitive study that indicates what the optimal level of blood pressure should be or what medications should be used to control blood pressure. So one of the questions that the HALT study attempted to ask is, what is the ideal level of blood pressure control? So I mentioned the renin-angiotensin-aldosterone system. This is a hormone system in the kidney that normally serves to preserve the blood flow to the kidney in times of dehydration or low blood pressure. So whenever there is dehydration or low blood pressure, this system is activated. Angiotensin causes blood vessels to constrict. It makes aldosterone, which causes you to retain sodium. And under normal circumstances, this is a good defense mechanism. In PKD, the enlargement of the cyst results in compression of arteries, leading the kidney to think that there's an inadequate supply of blood flow. And that results in stimulation of these two hormones, renin, angiotensin II, and then aldosterone. It's not important that you remember the details of this, other than to say that aldosterone is a very important hormone that causes salt to be retained, and angiotensin II is a very important hormone that causes blood vessels to constrict. So the combination of blood vessel constriction and retention of salt leads to the development of hypertension. Angiotensin also has some other effects. It can cause fibrosis or scarring of the kidney, and it causes cells to divide or proliferate, which again, that's part of the reason for the growth of cysts. So the HALT studies consisted of two clinical trials. Study A focused on individuals who were younger and healthier, who had better preserved kidney function with a GFR, an estimated GFR greater than 60. And remember, the normal GFR is between 90 and 120. Study B focused on individuals who were at an older age range, but who had reduced kidney function, so their baseline estimated GFR was greater than 25 and less than 60, so clearly reduced. The outcomes of the two studies differ, both the primary and secondary. As many of you have seen this diagram before, the HALT study had 7 clinical centers, Tufts and B.I. Deaconess Medical Center in Boston, Cleveland Clinic Foundation in Ohio, Emory in Atlanta, University of Kansas in Kansas, Mayo Clinic, and University of Colorado. And the colored areas indicate the catchment areas for each of the centers. So folks who went to Colorado had to come a much further distance than folks who came to Tufts and Beth Israel Deaconess, who were all living in the fairly congested Northeast. The Data Coordinating Center was located at University of Pittsburgh. So the hypotheses of the HALT study for study A is that low blood pressure versus standard blood pressure control will reduce the rate of disease progression measured by a change in total kidney volume. And you can see the ranges for the low blood pressure, 95 to 110 systolic over 60 to 75 diastolic. Standard blood pressure control 120 to 130 over 70 to 80. In study A was the only study where we looked at two different levels of blood pressure. In both study A and study B, we looked at a combination of medications to block the renin-angiotensin system. And this combination included angiotensin-converting enzyme inhibitors such as lisinopril and an angiotensin receptor blocker. We used one called telmisartan, but there's other sartans like losartan and irbesartan, etc., that block the angiotensin receptor directly. So I'm going to focus now on study A and the blood pressure intervention. And the primary and secondary endpoints of the studies are shown in this slide. Study A focused on the percentage change in total kidney volume. That is, if the medicine was effective, if the low blood pressure was effective, it would reduce the rate of growth of kidneys. In addition, in study A, we looked at a number of secondary endpoints. But it's important to remember that the most important endpoint in any clinical trial is the primary endpoint. So we looked at the slope or the rate of change of glomerular filtration rate decline. We looked at urine albumin, which is urine protein, and aldosterone. We looked at the thickness of the heart muscle, the left ventricular mass index. We looked at kidney blood flow and renal vascular resistance. Renal vascular resistance is a measure of how much constriction of the renal arteries that there is. In addition, we looked at the frequency of hospitalizations of any etiology and also related to cardiovascular complications. We also looked at quality of life, pain, and other PKD-related symptoms such as abdominal distension, infection, stones, etc. And just to focus this in a slightly different fashion, this is a graphic which really illustrates what study A and study B looked at. Study A looked at individuals who had relatively well-preserved kidney function, and we focused on the growth of kidneys. Study B looked at people who had already lost substantial amounts of kidney function, that is, they were down below 60, and they were on this downhill decline. So this is a very busy slide, and I'm just going to go through some main points. Starting at the top, we assessed 1,156 patients for participation in study A. By the time we got them through screening, we washed out their prior blood pressure medicines. We're actually able to randomize or enter into the clinical trial 558 individuals. And these were divided into 284 for standard blood pressure and 274 for low blood pressure. And then at the bottom of the slide, it indicates the number that actually participated in the study and were there long enough to be analyzed. And you can see it's about 140 per group. So with the standard blood pressure, there were about 140 that were on lisinopril telmisartan, and there are 143 that were on lisinopril and placebo. And similarly, in the low blood pressure group, there were 132 that received the lisinopril telmisartan, and there were 139 that received lisinopril with placebo. We compared the baseline characteristics of each group, that is the standard blood pressure group and the low blood pressure group, and essentially there were no differences. The same percentage of men and women in each group, about 50%. Individuals were mostly white with a small participation of African Americans. 70 to 78% had PKD1, the more common form of PKD. And these individuals were relatively young. You can see that the average age is about 36, slightly overweight with a BMI of 27.1 and 27.3. And their estimated GFR was pretty good. It's about 91. So first I'll show you the home blood pressure, and then I'll show you the urinary aldosterone excretion levels. And all of these figures are available in the publications that were submitted to the New England Journal and published November 15, 2014. In the panel on the left, the levels of blood pressure are shown for the standard and the low blood pressure group. And you can see we achieved excellent separation of blood pressure, both systolic on the top and diastolic on the bottom. So on average, the systolic blood pressure was about 120, a little bit more, in the standard blood pressure group, which by any means of measurement is excellent blood pressure control. And in the low blood pressure or the intensive blood pressure group, you can see it's below 110. And again, a separation of about 13 millimeters of mercury. The diastolic blood pressures, the lower number, were separated equally well in the standard group with a reading of about 80, and in the low blood pressure group, reading of about 71 or 72. Again, an excellent separation. So the next panel shows the impact on the urine aldosterone. Now, if urine aldosterone goes down, it means we were very effective in blocking the renin-angiotensin-aldosterone system. And in fact, in the low blood pressure and the standard blood pressure group, we very effectively decreased the level of urine aldosterone, and it was not different between the two groups. The next slide shows what would be the primary outcome of the study, and this is on a logarithmic scale, so the differences are minimized, but the standard blood pressure group had a more rapid rate of increase in kidney volume, about 6.57% per year, which is pretty fast. And the group with the low blood pressure control, that is the more aggressive blood pressure control, the rate of increase was only 5.67% per year. And this was a highly statistically significant difference, and it resulted in a 14% decline in the rate of increase of total kidney volume. So this was the primary endpoint, and it was met, and it was statistically significant. The next slide illustrates the change in GFR slope. And this is a complicated slide. I'll try to take you through it. In the group treated with to the low blood pressure goal, you can see that GFR actually declined abruptly in the first 4 months. And this was a planned analysis that is, we accounted for this when we designed the study, because we knew that reducing the blood pressure would result in such an effect. And in the standard blood pressure group, there was no impact on the GFR in the first 4 months. When you follow these over the entire period of the study, you can see that the overall slope was not different. That is, this p-value of 0.55 indicates they're not different. So in the low blood pressure group, they lost 2.9 mLs per minute per year. In the standard blood pressure group, they lost 3 mLs per minute per year. However, if you just focus on the measurement of the slope, not including this initial point, that is just starting here, I'm using the mouse, I don't know if you can see that, starting at 4 months, the slope, the rate of decline of GFR, was ever so slightly less in the group treated to the low blood pressure goal. So this 2.7 versus 3.1 mLs per minute per year. And this is an important point. It didn't achieve what we would call statistical significance, but nonetheless is strongly suggestive of a benefit of this more intensive blood pressure control regimen on slowing the rate of decline of GFR. I'll next talk about some of the other secondary endpoints. So in the groups, we measured urine protein, and the group treated to the low blood pressure goal actually had a decrease in urine protein, as shown in the red lines, and the group treated to the standard level of blood pressure actually had an increase in urine protein. And we know that protein in the urine is bad, and this was a statistically significant result. And this is also suggestive of a benefit of the more aggressive treatment of blood pressure. When we looked at the impact on the cardiac muscle, that is the left ventricular mass index, again, the low blood pressure group had a steeper decline in the thickness of the heart muscle. So again, more severe, more strict blood pressure control resulted in a decrease in the thickness of the heart muscle to a greater extent than that in the standard blood pressure group. This is also significant and suggestive of a benefit to lowering the blood pressure to such a degree. And finally, the renal vascular resistance, the measurement of how constricted the kidney arteries were, was lowered to a greater extent, this red line, in the low blood pressure group as compared to the standard blood pressure group. So several different markers of benefit to the kidneys. We also measured adverse events, and there was, because it's something that's done in any study, so we had almost 6 years of follow-up. There was no difference in the frequency of adverse events in the low blood pressure group versus the standard blood pressure group, and we looked at acute kidney injury, elevated potassium, hospitalizations, cardiac hospitalizations, and death. There was only one individual who passed away in the study A group during this study. So no difference in adverse events despite this low blood pressure. Slightly increased likelihood of lightheadedness. So the conclusion of the HALT study A blood pressure arm is that treatment of blood pressure to low levels, that is much lower than we're accustomed to using, in young, healthy, hypertensive ADPKD patients using these drugs, renin-angiotensin system inhibitors, is well tolerated and safe. It results in a 14.2% slower rate of total kidney volume growth over 5 years, reduced left ventricular mass index, reduced urinary albumin excretion, and reduced renal vascular resistance, and without a major impact on the change in kidney function. So I'll talk more about the meaning of that. I'm now going to switch over to study B, angiotensin blockade in late ADPKD, and I'm also going to talk about the use of ACE, that is lisinopril versus lisinopril plus telmisartan in this study. So again, the hypothesis is that dual blockade of the renin-angiotensin-aldosterone system with ACE inhibitors and angiotensin receptor blocker will reduce disease progression as compared to ACE inhibitor therapy alone. So this just shows that we recruited individuals ages 18 to 64. Their estimated GFR was 25 to 60, as I showed you earlier. Their blood pressure target was a standard blood pressure target, 110 to 130 over 70 to 80. These individuals did not have MRI measurement of total kidney volume. Again, we had a screen over 1,000 patients, actually 1,301 patients, to result in enrollment of 485 patients, of whom about 426 completed the study. So it takes a lot of patients to result in people who are actually eligible to participate in the clinical trial. So again, the primary outcome in study B was different than study A. It was not total kidney volume because we didn't measure MRIs. The endpoint was a composite endpoint, which was the time to death, time to ESRD, or a 50% reduction in estimated GFR. So if you reach any one of those points, that's the primary endpoint and how long it would take to do that. Again, the secondary endpoints are the same, other than there was no measurement of left ventricular mass index, and there was no measurement of renal vascular resistance. But all the other measurements were the same. And again, the baseline characteristics were compared between the different treatment groups. So if we look at study A, now these include people treated to either blood pressure goal. About the same percentage of men, mostly whites, mostly PKD1. Again, young individuals, 36, 37, with well-preserved GFR. If we look at study B, the two columns on the right, these individuals, about 50% male, again, mostly white, mostly PKD1, and you can see they're about 13 years older than the study A individuals, and their GFR is below 50, that is 49 versus 48 on average. And this is what we expected because study B contained a sicker population of patients. I'll talk about the blood pressures first. So in study A, with the two different medications, you can see that there was no difference in the blood pressure whether we used lisinopril and telmisartan or lisinopril alone, and that was true for the systolic, the top red and blue line in the panel in the upper left, or the diastolic, the red and blue line in the panel in the upper left. In addition, there was no difference in urine aldosterone excretion. That is, the combination of medicines was no more effective in blocking urine aldosterone excretion than lisinopril alone. And in study B, we achieved a similar result. That is, the blood pressures were extremely well controlled. They were not different between the two medication subsets, and urine aldosterone was increased to a comparable degree and not different between the groups. If we focus on the primary endpoint, in study A, there was no difference between the lisinopril telmisartan versus lisinopril placebo in the rate of total kidney volume growth, 5.9 versus 6.2% per year. In study B, there was no difference in the composite endpoint, that is the time to death, ESRD, or the 50% decline in GFR. And you can see the red line here is lisinopril placebo, and the blue line is lisinopril alone. This is the composite. If we break this down into its components, so again, no difference in the rate of death, no difference in the rate of end-stage renal disease, and no difference in the rate of, in the number of people with 50% GFR decline. If we look at the secondary endpoints, which are the GFR slopes, again, no difference between lisinopril telmisartan or lisinopril placebo. On the left panel, the slopes are the same, about 3 versus 2.86 mLs per year. And again, in study B, the combination was no more effective than the lisinopril alone. And as expected, people in study B had a faster rate of decline of kidney function at a rate of about 3.9 mLs per minute per year. In study A, there were no differences in the thickness of the heart muscle or the albuminuria, that is protein in the urine, no difference in the frequency of PKD-related symptoms, and no difference in quality of life or pain. Similarly, in study B, no differences in albuminuria, symptoms, quality of life, or pain. In terms of adverse events, again, there were no differences. The adverse event rates were low. So if we look at study A, comparing the two medication groups, followed for 5.6 to 5.7 years, low rates of AKI, elevated potassium, hospitalizations, and no difference between cardiac-related or other hospitalizations. In study B, the follow-up was similar, slightly higher rate of AKI, or acute kidney injury. There was more hyperkalemia, elevated potassium, which again is something we expect in individuals with reduced GFR. And no difference in hospitalizations or cardiac-related adverse events. And again, the death rates were similar in both studies. So the conclusions are that using an ACE inhibitor alone is safe and achieves excellent blood pressure control in most patients with ADPKD and CKD stages 1 to 3. Addition of an ARB, although safe under the conditions of HALT PKD, does not confer additional benefit. So it takes a lot of people, a lot of time, and a lot of resources to do a study such as this. The institutions and the participants are shown on this slide. We thank the ADPKD participants in the trial. All of the investigators and study coordinators are not listed on the previous slide. Data and Safety Monitoring Board, the National Institutes of Health, the PKD Foundation, which assisted in many ways by contributing a substantial amount of money to help pay for study coordinators in the beginning, and who helped extensively with recruiting patients through blast emails and publications and the PKD Foundation website. In addition, Boehringer Ingelheim Pharmaceuticals donated the telmisartan and the placebo, and Merck donated the lisinopril. So that's the end of my formal slide presentation. I realized I presented a lot of technical information, and I'd be happy to entertain any questions or clarifications from the group. And thanks for tuning in.
Well, thank you so much, Dr. Perrone. And we're going to open it up to questions now. If you have any questions, feel free to either type it in the chat box, or I will unmute everyone, since there are, few enough participants on right now that there will be minimal background noise. So I will unmute everyone, and we'll just wait and see if we have any questions.
I have a question. I was wondering why lisinopril was used specifically. No, it's chocolate. It's chocolate. Gingerbread, I guess you could probably do that, maybe. I don't know what the recipe would be. I was just trying to think of things that would be good. Trying to see, my office is doing a web seminar, and I'm like trying to listen a little.
All right, we're going to put everyone back on mute. Sounds like there's a lot of background noise, so.
So I haven't seen any questions come up in the chat box, although I think that there actually is one more slide. If we could just go to the last slide, and perhaps we could use this as or the previous slide, 2029. Thank you. So I'm sure a question that everybody has is, how will these results translate to clinical care? So one very important issue is that doctors can use an angiotensin converting enzyme inhibitor alone rather than combined with an ACE and an ARB, and that would be sufficient. And that's a big deal because it makes the treatment of hypertension and ADPKD simpler, and with less concern about causing trouble with the combined therapy. In younger individuals with preserved kidney function, a lower blood pressure target that is below 110 systolic had protective effects on kidney size, heart muscle, and urine protein. And the impact on kidney function was borderline, and but will require longer-term follow-up to determine whether this is an effect that will be evident in the next 5 to 10 years. We're hoping to get funding from NIH to continue to follow the HALT patients, but this has not been determined definitively yet. And sometimes it takes longer to determine such an effect than just the 6 years of the study. So there was a question about why did we use lisinopril. Lisinopril is a generic angiotensin converting enzyme inhibitor. It lasts for 24 hours, and it's a very commonly used medication, and would not be expensive to use in clinical practice. And it's an excellent angiotensin converting enzyme inhibitor.
Dr. Perrone, I have another question for you.
Okay.
Can you start an ACE inhibitor if you don't already have high blood pressure?
Well, for a younger person, I think the definition of high blood pressure is now lower. That is, in my practice, I would target younger individuals to use an ACE inhibitor when their blood pressure is above 110. So up until now, that's not been considered hypertension. So we now think that this goal might be useful. And of course, this depends on whether someone's actually been diagnosed, whether they're willing to follow up closely, whether they're compliant with medications, etc. But I think you might consider initiating treatment. You might consider treatment of hypertension earlier in ADPKD. Okay, are there other questions?
So once again, everyone is muted, but if you would like to ask a question of Dr. Perrone, you can type it into the chat box in GoToWebinar. Okay, I've got another question. So previously we've heard that without a treatment for PKD, it doesn't make sense to get tested if you're not having other issues. Do we now think that young people should get tested?
That's an excellent question. One of the issues about not getting tested for PKD relates to issues with insurability and potential discrimination. I would think in a PKD family where people haven't been diagnosed, it's a difficult decision to decide to test a young person. But I think that individuals in their 20s and 30s would probably be well served by getting, having their blood pressure followed very closely and having treatment initiated. One can treat hypertension without making a diagnosis of PKD, but I don't think I would treat someone with normal blood pressure unless I had a definitive diagnosis of PKD. So yes, it would be important to be tested, but I'm not sure this should be cause for everyone dragging their kids to go get an ultrasound unless they're prepared for the consequences of that.
All right, and I have one more question. Was there any impact on pain in this study?
There was not, although a detailed analysis of impact on pain and quality of life will be forthcoming. We hope to have a number of secondary analyses which will look at many other aspects of the study, and these analyses remain to be done.
Okay. Do we have some more questions coming in. Would you recommend all healthy youngish people with ADPKD to go on lisinopril or another ACE inhibitor?
Again, that's a difficult question, and I'm not sure we can answer that definitively. Certainly, if they, in order to get into the HALT study, you had to have a blood pressure higher than 130/80. And then once you had demonstrated a blood pressure higher than 130/80, you were then treated to one of the two different blood pressure goals. I don't think I would treat every young person with ADPKD with an ACE inhibitor based on the results of the HALT PKD study at this time. But I think I would certainly monitor blood pressure very closely, and should there be labile hypertension, that is intermittent elevation of the blood pressure, I would certainly consider initiating treatment.
All right, another question. In study A, was cyst percentage of TKV measured? Was it impacted by blood pressure control? Was renal blood flow affected by blood pressure control?
Yes. The growth of cysts, as measured by total kidney volume, was less in the group treated to the lower blood pressure target. That was the primary endpoint of the HALT study, and it showed a benefit. The combination of lisinopril and telmisartan was not any more effective than lisinopril alone in reducing the rate of growth of kidney volume or impacting renovascular resistance.
All right, another question. One of our panelists said, I see that lower blood pressure was advantageous in study A. Was it also effective in study B, especially regarding TKV?
In study B, we only used one blood pressure target, so we did not actually treat individuals in study B to a lower blood pressure target. And the reason for that, it was thought that with the combination of ACE and ACE plus ARB, we would potentially cause a lot of problems with kidney function, resulting in acute kidney injury and elevated potassium. So only one blood pressure goal was addressed in study B. In addition, in study B, we did not measure total kidney volume. So we were not able to determine an effect on total kidney volume in study B. We think that total kidney volume is an important thing, particularly in the early stages of disease, to look at.
All right, we're still getting questions, so I'm going to keep on going here. What does the HALT acronym stand for?
Actually, it doesn't stand for anything except the word HALT.
Okay. Another question. Is there a reason lisinopril was used over other ACE inhibitors?
Lisinopril was chosen because it has a 24-hour effect. That is, it only needs to be given on a once-a-day basis, and it's a very commonly used generic medication, so it would not be expensive. I think you could use any ACE inhibitor, though, and probably get the same result, but we did not test that.
All right, here's another question. Given that almost all the endpoint results from the use of ARBs were equal to or slightly better than without ARBs, why wouldn't they be better recommended in addition to ACE inhibitors?
Well, the results in the HALT study did not show a greater benefit of the combined therapy versus lisinopril alone. So there's no reason to use the combined therapy. There are actually many other studies in different kidney diseases, primarily diabetes, which show that the use of an ACE plus an ARB together are actually harmful. We did not find that to be the case in PKD, but nonetheless, the study showed that there was no additional benefit to be gained by using the two of them together.
Okay, another question. Will the results of the HALT study have an impact on TKV as a diagnosis?
No, there shouldn't be any change in diagnosing kidney volume or diagnosing PKD as a result of the HALT study.
Okay, another question. How did the dosages of lisinopril vary between the low blood pressure and standard blood pressure groups?
Well, the combination of ACE versus ACE plus ARB resulted in a slightly greater use of lisinopril. I think 6 milligrams per day more of lisinopril when it was used alone than when it was used with a combination with the angiotensin receptor blocker. I didn't cover in the slides because I didn't want to make it overly complicated, but if blood pressures weren't adequately controlled by the ACE plus ARB or placebo, we added additional medications, including diuretics and beta blockers. And then if the addition of diuretics and beta blockers was not effective, we added other medications on top of that.
Okay, another question here. Was renal blood flow measured as opposed to vascular resistance, or are these both measures of the same thing? Was it impacted by blood pressure control?
Renal blood flow was measured using the MRA technique, and we're able to calculate renovascular resistance by virtue of the fact that we measured renal blood flow. And there was no impact of the interventions on renal blood flow. But because of lower resistance, it suggested that the kidney was healthier.
Okay, we're still getting questions here. How is an ACE inhibitor different than other blood pressure medications?
An ACE inhibitor is different than other blood pressure medicines because it blocks the conversion of angiotensin 1 to angiotensin 2. And the only other blood pressure medicines that do that are other angiotensin converting enzyme inhibitors. Other blood pressure medicines will dilate blood vessels, or for example, diuretics will get rid of salt and water. Calcium channel blockers cause blood vessels to dilate directly. So there's many different mechanisms of how blood pressure medicines work.
Okay, we're still taking questions here. If a PKDer is taking lisinopril and is in standard range, could he take a lower dosage of lisinopril to lower his blood pressure to the low standard?
Well, in order to lower your blood pressure to a lower target, you would actually need to take more lisinopril. But that should only be done under a doctor's supervision. And whenever you increase the dose of lisinopril, it's important to check the potassium level in the blood a week or two after that, just to make sure you haven't raised it to a higher level.
Okay. Will the results of the HALT study help prove that total kidney volume is an appropriate endpoint for PKD?
That's an excellent question. If there was a definitive effect on GFR, this would have been a very important demonstration that TKV is a good endpoint. Unfortunately, the effect on GFR was equivocal, and it's believed that this effect will be revealed if we're able to follow these patients for a longer period of time. You know, PKD takes on average 55 years to lead to kidney failure. It's a slowly progressive disease, and a study that's 5 or 6 years in duration just may not be long enough to demonstrate this effect.
Okay, another question here. Was salt intake monitored?
Yes, we measured 24-hour urine sodium excretion on a yearly basis, and there were no differences in the groups, and actually people ate more salt than they should have. But there was no impact of salt intake on the results.
Okay, I think I've addressed all the questions, but if you asked a question and didn't get an answer, feel free to type it in again, and I'll make sure and get it out to Dr. Perrone. Okay, here I have another question. If a PKD patient has blood pressure of 170/70, would this be considered standard or low? Which number is more important?
The top number in this case is the most important, and that's much too high, and it should be lowered to a safe range.
All right, any more questions?
There is one question I see about, is there anything we can do to lobby the NIH to continue funding for the HALT PKD study? I think the NIH is interested in doing that, and we're having active discussions about this now. The study wouldn't be continued in the same form, but there needs to be some long-term follow-up of the patients, and to see if the protection for total kidney volume translates to a long-term benefit in kidney function.
I'll quickly add, I got a comment that said, thank you for the excellent discussion.
Well, thank you for tuning in, and thank you all for your excellent questions and everything you do to help support the battle against PKD.
All right, before we wrap up, Michelle, any final thoughts?
Thank you, Dr. I was just going to say thank you so much, Dr. Perrone, for all of the time and energy that you and the other folks that you showed us in that very first slide have put into this study. We're grateful for your leadership on this project, and we're grateful to our supporters who helped make it possible, and the study participants. So if you have any other questions that come up after this, or you have other questions about work of the PKD Foundation and things that we're working on, you are always welcome to reach out to me. And if you'll just send an email to Michelle, M-I-C-H-E-L-L-E, D as in Davis, at pkdcure.org, or you're welcome to call me at 816-268-8477. I am glad to get back with you. And again, thank you so much, everyone, for participating tonight. We will have this available to you to share with others or to listen again on Monday. Have a great evening and happy holidays.
Thank you, Dr. Perrone.
Thank you.